Gastrectomy is the removal of part or all of the stomach. There are three main types of gastrectomy. A partial gastrectomy is the removal of a part of the stomach. The lower half is usually removed. A total gastrectomy is the removal of the entire stomach. A sleeve gastrectomy is the removal of the left side of the stomach. This is usually performed as part of a surgery for weight loss. Gastrectomy, partial, distal, with gastrotomy. With gastrojejunostomy, the physician makes a midline abdominal incision. The distal stomach, antrum, is dissected free from surrounding structures and the blood supply to the antrum is divided. Next, the gastroduodenal junction is divided and the stomach is divided in its middle portion, removing the antrum. An anastomosis is made between the proximal stomach and the duodenum or jejunum with staples or sutures. The incision is closed. Gastrectomy, partial, distal, with Roux-en-Y reconstruction. The physician removes the distal stomach, antrum, and performs an anastomosis between the proximal stomach and a Roux-en-Y limb of jejunum. The physician makes a midline abdominal incision. The gastroduodenal junction and the middle portion of the stomach are divided and the antrum is removed. The proximal jejunum is divided and the distal limb of jejunum is connected to the proximal stomach. The proximal jejunum is connected to the limb of jejunum distal to the gastrojejunostomy to restore intestinal continuity. The incisions are closed. Gastrectomy, partial, distal, with formation of intestinal pouch. The physician removes the distal stomach, antrum, and performs an anastomosis between the stomach and a pouch formed of jejunum. The physician makes a midline abdominal incision. The distal stomach is dissected free of surrounding structures and the blood supply to the antrum is divided. The gastroduodenal junction and the middle portion of the stomach are divided and the antrum is removed. The proximal jejunum is divided and the distal end is folded upon itself and approximated in such a way to form a pouch. The pouch is connected to the proximal stomach and the proximal end of the divided jejunum is connected to the jejunal limb distal to the pouch anastomosis to establish intestinal continuity. The incision is closed. Gastrectomy, total, with esophagoenterostomy. Gastrectomy, total, with Roux-en-Y reconstruction. The physician makes a midline abdominal incision. The stomach is dissected free of surrounding structures and its blood supply is divided. The stomach is divided at the gastroesophageal junction and at the gastroduodenal junction and removed. In 43,620, the remaining duodenal end of the intestine is simply mobilized to the end of the esophagus and connected. A measured limb of Roux, or limb of small intestine, is created by dividing the upper jejunum. The distal part of the now divided upper jejunum, the limb in continuity with the ileum, is brought up and anastomosed to the esophagus. The proximal end of the divided jejunum, the segment containing the duodenum, must be connected back into the limb of small bowel farther down from the esophageal anastomosis. Gastrectomy, total, with formation of intestinal pouch, any type. The physician makes a midline abdominal incision. Next, the stomach is dissected free of surrounding structures and its blood supply divided. The stomach is divided at the gastroesophageal junction and the gastroduodenal junction removed. The proximal jejunum is divided and the distal end of bowel is folded upon itself and approximated in such a way to form a pouch. The pouch is connected to the esophagus. The divided proximal jejunum is connected to the limb of small bowel distal to the esophageal anastomosis to restore intestinal continuity. The incisions are closed. Gastrotomy, with exploration or foreign body removal. With suture repair of bleeding ulcer. With suture repair of pre-existing esophagogastric laceration, e.g., Mallory-Weiss. With esophageal dilation and insertion of permanent intraluminal tube, e.g., Celestin or Mousseaux-Barbin. The physician performs a gastrostomy and explores gastric area, removes a foreign body or corrects a mucosal defect. The physician makes a midline epigastric incision and retracts the skin and underlying tissues laterally. The stomach is incised and explored. In 43,500, a foreign body is removed. A bleeding ulcer is identified and bleeding is controlled with electrocautery or ligation of vessels, and the mucosa is drawn over the ulcer and sutured. In an esophagogastric laceration is identified and bleeding is controlled with electrocautery or ligation of vessels, and the mucosa is drawn over the defect and sutured. The physician introduces dilators into the esophagus from the stomach to increase the diameter of the esophagus. When dilation is complete, a stent is placed and secured with sutures to maintain patency. After exploration or repair, the stomach is sutured in layers, the soft tissues are returned to anatomical position, and the incision is sutured in layers. Duodenal exclusion with gastrotomy for pancreatic injury. The physician performs duodenal exclusion and gastrotomy for a pancreatic injury. The physician makes an abdominal incision and explores the abdomen. The pancreas is exposed and an injury in the duodenum or pancreas may be closed with sutures. An incision is made in the stomach, gastrotomy. The natural opening from the stomach to the duodenum is closed with sutures or staples. A limb of proximal small bowel is brought up to the stomach and an anastomosis is performed, gastrotomy, at the site of the gastrotomy. The abdominal incision is closed. Pancreaticojejunostomy, side-to-side anastomosis, pusto-type operation. The physician creates a pancreaticojejunostomy to drain pancreatic enzymes through a side-to-side anastomosis. The physician makes a midline epigastric incision and retracts the skin and underlying tissues laterally. The physician approaches the pancreas through the lesser sac of the omental bursa or through the transverse mesocolon. A jejunal loop is brought up to create a fistula for enzyme flow to the digestive tract. Bleeding is controlled and the lesser sac is closed. Tissues are reproximate to the anatomical position and the incision is sutured in layers.